Hi everyone, thanks for joining this Becoming a Doctor session. So this will be a practical guide to extrapyramidal side effects, hosted by Dr. Britton Baker. So just some house rules for everyone. If you have any questions or comments, feel free to put them in the chat. Anything in a more general sense that you want to ask, put them in the Q&A and we will address them at the end of the session. For all the questions, the polls are built into Zoom, so you don't need to go to any Mentimeter or any other website for that. And if you are watching on the Facebook, feel free to question or comment, and Dr. Baker will address your comments during the session itself. Otherwise, have fun, and off to you, Dr. Baker.
Cool. Yeah, so my name is Britton. I am a CT2 psych trainee. I'm based in Northwest London. Yeah, just an introduction about me. I'm obviously you can tell I'm American. I did my undergraduate in America in Utah, and postgraduate with St. George's in Cyprus, and did clinical years in Tel Aviv, and then foundation year here, and now a psych trainee here in London. So this is probably my first webinar I've done, so looking forward to it. Yeah. Let's just, I guess, start about what we'll be covering today. So first of all, we'll just be talking about some of the definitions of EPSEs, the causes of EPSEs, pathophysiology, common EPSEs in the presentation, and then we'll go into a little bit about neuroleptic malignant syndrome, and see how we can tie that into serotonin syndrome, because that's something they like to ask about on questions quite a bit. And then we'll go to treatments as well as rating scales for EPSEs that we can use. So EPSEs, I guess before we start, I think it's always important to ask yourself why we need to cover this topic, why it's important. And I think, first of all, because EPSEs are notoriously tested out of psychiatry questions. I find that they're tested because it's a good multiple choice question, and also because it's sort of dealing with some of the more physical health aspects of psychiatry as well. And also, if you figure them out practically, like in A&E, or if someone comes in, you'll be treated like a god amongst psychiatrists if you do notice these things. So I think that that's also good for when things do become more practical and spotting these things and spotting what medications people are on as well. So a definition of these extrapyramidal side effects are that they are a set of specific movement disorders. We can classify them into acute disorders and long-term, and that sort of ties in with their pathophysiology, which we'll get into. Obviously, it comes from the extrapyramidal system, which is affected when you take certain antipsychotics and other medication. Now, in psychiatry, we like to deal with specific brain pathways. And I don't know how much each med school tests on these pathways, but I think it's important to know about them. Because there's four main pathways that we use in psychiatry, and which are affected by the psychotropic medication that we put people on. So the first one is, and probably the most important one, is the mesolimbic pathway. This is the pathway in the brain which is associated with psychosis, all the positive symptoms you see with a lot of psychiatric presentations. And so we use psychotropic medication to change the amount of dopamine in that part of the brain, in the mesolimbic pathway. And then the mesocortical is the next pathway. That's sort of the pathway that's associated with the negative symptoms of schizophrenia. I like to think, I remember it, I just think me so poor is how I remember it. So like, I'm so poor, these are all the negative symptoms of that and of schizophrenia. So that's how I remember that. And then the other pathways are also affected by psychotropic medications. The tuberoinfundibular pathway is mainly associated with sort of the hormonal regulation, and that's why some psychotropic medication can cause people to have hyperlactin. That's something we're always checking, or gynecomastia, or galactorrhea. So that pathway is associated with the increase in prolactin as a result of dopamine. And then the one that we're looking at today is the nigrostriatal pathway. And that's dealing with the motor control and the effect from antipsychotic medication. So as just to go over what I said quickly, too much dopamine in the mesolimbic pathway can cause psychotic symptoms, paranoia. Antipsychotics decrease this dopamine, and the nigrostriatal pathway is then affected because it uses dopamine as its messenger. So you have a D2, the dopamine 2 receptor blockade, and then as a result of having that blockade, you have an increased acetylcholine release, which can cause extrapyramidal side effects. There's just a picture right there, which sort of demonstrates this. In picture A, you see how it's normally meant to be. Dopamine affects the neuron, and it releases acetylcholine to have a normal motor activity. But as you put in a D2 antagonist, like an antipsychotic, you suddenly have a change in modulation, and you have an uncontrolled release of acetylcholine, which leads to increased muscle tone and all of these movement disorders. Now, that is usually, that effect is usually happening earlier on. And it's all about this balance. So first of all, as we see in this sort of second graph here, earlier on you get stiffness and dystonia because of once you have this blockade of dopamine, you get unmodulated acetylcholine release to counteract this decrease in dopamine. But eventually, and you use medications like anticholinergics to treat this, and eventually that will cause that to go down. But as time goes on, what happens is that the dopaminergic receptors are then upregulated, and then you have some of these long-term extrapyramidal side effects. And you'll see that actually then it's much more difficult to balance, and a lot of times these anticholinergics can make this worse. I just want to just quickly have a look and see if there's any questions right now. So there is one chat. Okay, yeah, so we're okay. So I hope we're all clear with that. It is a bit confusing, and it did take me some time to understand, but we can go over it again if it is needing a bit more time to understand that. But I think we'll talk about now the usual causes of this, and the most likely antipsychotics to cause this are always going to be haloperidol is the main one that you want to look out for. And I think that's something that in most med students exam, that's what they expect you to know of the first generation sort of dirty drugs that they like to call it, which can cause this. And then there is fluphenazine, amisulpride, and all these other ones. But I think haloperidol is the one you would most likely need to know for exams. Less likely to cause it is risperidone and paliperidone. And then the least likely to cause extrapyramidal side effects are medications like aripiprazole, olanzapine, and quetiapine. And then clozapine is always used as a last resort because clozapine has a whole host of other side effects which can cause a lot of complications. But usually you want to try at least two other medications before you switch to clozapine because of its risk for agranulocytosis. I just saw a Q&A pop up here as well. Sorry. yeah, we can go over that at the end again. Yeah, so those are the antipsychotics that we are most likely to see causing EPSEs. Some other medications can cause it. Antidepressants is a bit confusing because antidepressants affect the serotonin system, and I didn't really understand this until speaking with a consultant yesterday about why they do. But basically, some parts of the brain cause as you increase the amount of serotonin, it affects dopamine, and then that can lead to these EPSEs that you see. But that's more rare, but it can happen with antidepressants, and metoclopramide also affects dopamine as well. So the types of EPSEs. So the first one is dystonia. Next, you have Parkinson type symptoms or pseudo-Parkinsonism. Then you have akathisia, neuroleptic malignant syndrome, and tardive dyskinesia. And we'll go over each one of these and what they're associated with. So first one, and I guess it's important to say that these are the ones that will generally come up in MCQs. And dystonia is one that can be a bit more subdivided because there are different types of dystonia as well. So dystonia is likely to happen earlier on. It's one of the first types of EPSCs that you can get. It's usually 1 to 5 days after initiation of a new antipsychotic medication or any type of medication that can cause EPSCs. So what it is a very uncomfortable feeling, and it can cause a lot of people to stop their medication and say, actually, I don't want to deal with this anymore, because it's a scary thing that happens for people. So what it is, it's a sustained repetitive contraction in your muscle, which can be twisting or lead to sort of abnormal fixed postures or something like that. And it can affect different and specific muscle groups. So we'll just sort of go with this image right here. So within the face, you can have the oromandibular dystonia or Meji's syndrome, which is sort of causing involuntary opening and closing of the mouth or deviation of the jaw, including the tongue. So it's sort of like that. You can also have blepharospasm, which is a contraction of the muscle around the eye. And also associated with this is something which is called the oculogyrate crisis, which I'll show you an example of in the next slide. Another common one is cervical dystonia or torticollis, which is usually something which can be tested or which would be in multiple choice questions, and that is sort of when your neck becomes stuck like that, and it's quite painful and very uncomfortable for people who have it. And laryngeal dystonia can cause sort of a whispering development in the patient's voice if they are started on a new medication. So that's also something to look out for. I don't think that's as frequently tested. And then the next one is limb dystonia, and those can happen in the legs, these very strong cramps, or in the hands or elbows. So it's sort of like this. So in the next slide, there's an example of that, of how that tends to look. And just wanted to show you just a quick example of what it looks like in this oculogyrate crisis as well. So we have a young girl who is started on a medication, and we can see that they're trying to do an eye examination on her. And as it progresses, you see that she is unable to follow the finger, and you can see that her eyes are rolling back into the top of her head. And you can see that she's putting quite a lot of effort into getting her eyes to deviate back to how they normally should, and it appears quite uncomfortable for her. It doesn't seem like something that you would enjoy experiencing, for sure. So that's the types of dystonia generally. For these, the main management is first to reassure. I think a lot of people can become very scared to have such a strong reaction and to not know where it's coming from. The next one is procyclidine and anticholinergic drugs. As it is earlier on, as you've decreased the dopamine in the system, the ACH is firing without any management, and so you want to decrease the amount of acetylcholine in the system to help with this. The next plan would be to change the antipsychotic, try to get them on something else like aripiprazole or clozapine if they've already been on 2 antipsychotics. And sort of the last resort, if none of these things work, is you can try an injection of Botox. Okay, so I hope we're still with me. Next is pseudo-Parkinsonism. We call it pseudo-Parkinsonism because it's not actual Parkinsonism, it's drug-induced or iatrogenic. So this is going to look very similar to Parkinsonism. You're going to have rigidity, bradykinesia, tremor, mask faces, shuffling gait, and stoop posture. It's also going to be at a higher risk of happening in elderly patients or who are presenting with psychotic symptoms. And it is going to occur about 1 to 4 weeks following medication initiation. So still early on, I'm still considered within the acute phase, which is sort of days to weeks. Yeah, I mean, I think that's pretty straightforward for the pseudo-Parkinsonism. So just on MCQs or in real life, just look out for what medication patients are on, and rule that out prior to diagnosing with Parkinsonism as well. For the management of this, you want to reduce the dose of the medication, change the anticholinergic medications as well, or add those in, and change to a different antipsychotic as well. So that's the pseudo-Parkinsonism. The next is akathisia. So akathisia is, it's a Greek word. Kathizo is to sit, and when you put the A in front of the word, it means unable to. So it literally means the inability to sit. And it's this inner restlessness that people can have associated with this. This is more associated with longer term antipsychotic use, months to years. People fidget, rock back and forth, or pace. And if you look at this gentleman, you can sort of see how uncomfortable it is to live with this on a daily basis, to have to deal with this inner restlessness. I think that a neuropsychologist had it for 2 days and described it as the worst feeling they've ever had in their whole life, and wouldn't wish it on their worst enemy. So it is one of these things that is really uncomfortable for the people who do experience it. The first generation antipsychotics like haloperidol or fluphenazine, or that list at the beginning, are usually the cause of akathisia. So the best way to do this is to, again, similar approach, except for the anticholinergic. So you want to decrease the dose, switch medication, but because of the pathophysiology, anticholinergics make this worse. So because this is a longer term side effect, it's not as associated with with the acetylcholine, it's more associated with the fact that with the decreased dopamine levels, the dopamine receptors, the D2 receptors, have been upregulated and are very hypersensitive, and leads to this side effect. You can use medications like propranolol, clonazepam, trazodone, all these medications. I don't think that's really useful for the exam, because I think that's getting a bit too specific. But I think it's important to be able to differentiate akathisia from other side effects. Next is a very important one that they love to test on, because it's one of the few psychiatric emergencies. This and serotonin syndrome are kind of the two where they tend to throw in a question quite regularly and ask you to differentiate the two. So we'll go into that as well. So neuroleptic malignant syndrome is a medical emergency, has 10% mortality. Oh, sorry, Q&A. I'll go into symptoms of NMS as well. And, oh, sorry, are the symptoms of pseudoparkinsonism, like the tremor, etc., unilateral or bilateral? I don't actually, I think it is bilateral. In the patients that I have seen, I think it is bilateral, but I wouldn't be surprised if it's also unilateral as well. So I guess the real answer is I'm not sure if it's unilateral or bilateral. Maybe I can look that up later. So we'll go to NMS as well. So medical emergency. The main features of this are muscle rigidity and lead pipe rigidity, so very, very strong. Fever, sustained fever, and unstable blood pressure. Muscle rigidity and fever are the two main things that you want to look for, and that are very similar between neuroleptic malignant syndrome and serotonin syndrome. You'll also have confusion as well, and a change in mental state. The cause of neuroleptic malignant syndrome is unknown, but it's related to this dopamine receptor blockade, and that's what's central to most theories. So, as far as the mental state change, it can be delirium, lethargy, stupor, even a coma. And you'll have diaphoresis, tachycardia, tachypnea, dyspnea, hypoxemia, drooling, hyperthermia, increased cerebral blood pressure, and then muscle tone will be rigid with possible agitation, tremor, shuffling gait, sometimes dysphagia, and very rarely incontinence. So these are the main things that you're going to want to look out for as you're doing that. But I think the main things that they'll focus on for the exam is these four: is the muscle rigidity, fever, unstable blood pressure, and confusion. Management of this is, oh, sorry, let's see. Can NMS affect laryngeal muscles and affect the patient's ability to speak? Not that I've ever heard of. I've never heard that listed as a common side effect of it. But again, it's possible that it could be because it is affecting the muscles as well, but not something which is very common. So the management of this is going to be to withhold antipsychotics. You're going to want to send them to A&E as soon as you can. In A&E, they'll check for the creatinine kinase and myoglobin, because of the rigidity of the muscles will cause breakdown of the muscles. That will then affect the kidneys, block the kidneys, and cause severe kidney damage. Another thing that they're going to want to do is aggressive temperature control with cool blankets and ice packs for these patients. And usually they're going to be pretty quick to admit them to ICU, plus or minus ventilation as well. So that's the main thing. And then wait until everything comes out of their system. So just for the exams, the difference is obviously first of all is going to be in the history that they give you. You're going to want to know what's an SSRI and what's an antipsychotic. So, and that's going to be a huge hint in the question if it is there. Sometimes they'll say, you know, patient had an unknown drug or whatever that they found, which led to symptoms. But sometimes they'll also just say they took, you know, an overdose of citalopram or something and expect you to know what citalopram is. The onset of serotonin syndrome, as opposed to neuroleptic malignant syndrome, is very abrupt, hours after taking these medications. And sometimes it can also, I guess it's not just necessarily a result of an overdose, but also sometimes there can be, in the question stem, it could be that they're cross-tapering between two medications, changing from one SSRI to another, and that's what's caused this. Yeah, so the course is rapid, whereas in NMS, it's usually quite prolonged, and they've been started on a new medication. The neuromuscular findings are also very important in differentiating the two. In serotonin syndrome, you are going to have myoclonus and hyperreflexia are the ones that I've been tested on the most and are always differentiating the two. Whereas in NMS, it's going to be lead pipe rigidity and bradyreflexia. So keep those two very distinct in your mind. So SSRIs cause hyperreflexia, and NMS is lead pipe rigidity. Pupils can be affected, dilated in serotonin syndrome, and normal in NMS. And GI symptoms are also going to be present in serotonin syndrome. And this is interesting, and I think that I guess one of the interesting things about the GI symptoms is the fact that I think there's been a lot of research about sort of the microbiome and the mind gut and that whole interplay. And I listened to a podcast called Ologies, where they had a gut expert coming in to talk about the microbiome. And serotonin is actually 90% of the serotonin in your body is actually produced in the gut as opposed to the brain. And so in serotonin syndrome, you're going to have a lot of GI side effects because of all this increased amount of serotonin as well. So I think just remember that the gut produces 90% of the serotonin in your body, and you're going to have a lot of these symptoms which result from serotonin syndrome. Let me just quickly check the questions which have been brought up. So, okay, we've discussed that. So how is myoclonus different to dystonia? So myoclonus is this specific it's on the neurological examination. Myoclonus is when you pull the ankle up and you get this quick jerking down of the muscle. Whereas dystonia is going to be different in the sense that it is going to be completely unrelated to you. It's going to be a sustained long contraction, whereas myoclonus is sort of like a quick jerk, which is done on the neurological examination. Yeah. Okay. All right. And I saw one more chat. And from Facebook, how long after starting antipsychotics does akathisia normally happen? So that is akathisia is, I've written that. It's at the end, so we'll get there. There's a slide which details that'll go over the timeline of all of these, so that we can discuss each one of these timelines as well. So lastly is tardive dyskinesia. So this is for people who have been on medication for months to years, usually for tardive dyskinesia, and it's characterized by repetitive involuntary movements of the face. So it's usually going to be associated with grimacing, tongue movements, tongue protrusion a lot of the time, lip puckering, pursing of the lips, and excessive eye blinking as well. It happens in patients on long-term antipsychotics, and it can fluctuate over time, but it can also, if you're seeing this, one way to tell if it is tardive dyskinesia is to have them do like a math problem, for example, and it will cause them the sort of dyskinesic symptoms to get worse as they're focusing on something else. It's also worse when they're emotionally aroused or angry or happy, and you can see that with them as well. There's a chap here who this is quite characteristic, this sort of mouth movement. They call this rabbit syndrome, and it's sort of associated with this movement in this gentleman's face here as well. But it's something which can really affect compliance of patients. Once you get it, it's notoriously difficult to treat, and people will, once they get it, it's something that will likely stay with them for a very long time, and really affect their ability or desire to remain compliant to their medication. Also, I think it's important to note that that this tardive dyskinesia isn't present during sleep. Most of these aren't present during sleep, of course, except for things like NMS. But that's one way to tell. Maybe, if you're worried that somebody's faking it, you can observe them during their sleep, and well, I guess that doesn't make sense, because if they're asleep, they wouldn't be faking it either. But maybe to differentiate between other neurological conditions, you would be able to see if it is present during sleep. So, what's the difference between dystonia and tardive dyskinesia is a question that somebody's asked. So dystonia is going to happen much earlier on, and it's usually a single occurrence, and it's a sustained contraction, whereas a dystonia is going to be repetitive in its nature, and it's going to be after someone's been on antipsychotics for a very long time, and it does have these sort of characteristic features as well. Does tardive dyskinesia stop when they stop medication, or can it persist? That's also a very good question. It persists. Because it is notoriously difficult to treat, it can go down a little bit. Sometimes it can go away, but sometimes it can also persist as well. So I don't have the numbers on how it's affected, but generally it can keep going even after you stop the medication as well. But sometimes for some people it can stop. Yeah. So will tardive dyskinesia decrease in severity? It can. So and that's what you want to try and see. So it is I think that once it does start to happen, once you notice someone has tardive dyskinesia, best to either change to the lowest possible dose of that medication if that's what they respond to, or discontinue. A lot of these patients who do have these symptoms have been on medication for a very long time, and then it becomes a discussion of balancing balancing the risk. So you could say, listen, we can change you to a different medication, but that might mean that you're going to relapse. And I think it's about having a frank discussion about this, and saying, you know, what do you prefer? What do you want to do here? Because the tardive dyskinesia might not go away, and you might also have a relapse as well if we do change you to a different medication. So I think at that point it really becomes a discussion with the person that you're treating about acting in their best interest. There are some things which can help. Tetrabenzene is the one which is licensed from NICE to treat this, and that can be added. That's not an antipsychotic, but that can be added to help with this as well. Ginkgo biloba has shown in some studies to work as well, and that can be taken over the counter as well. Generally, though, the people that I've seen on antipsychotic medication in the community have been switched to clozapine, because that seems to have the lowest side effect profile as well. Let me just check the questions. Okay. And yeah. Perfect. Okay. All right. So now we will go to, this is just a slide that will show you the side effects of the antipsychotics, and I just like it because it just shows everything a bit more briefly, and you can see the general time frame of these medications. So acute dystonia is early on. Parkinsonism is 1 to 4 weeks. Akathisia is 5 to 60 days as well. So that is relatively early on as well. And then neuroleptic malignant syndrome is weeks to months, and tardive dyskinesia is usually late months to years. All right. So next is just some of the rating scales that we use. The AIMS is the rating scale called, which is abnormal involuntary muscle scale. And that's usually something that, if you know the meaning, because it's just dealing with the abnormal involuntary movement, it's going to be the dyskinesias, the dystonias, and the akathisias. And this is something which is measured once, but then over time as well. It looks sort of similar to, I guess, the MMSE or things like that, where you want to check to see how changes in these medications affect the patients as well. The Angus-Simpson rating scale is the one that we use for Parkinsonism as well. So, how are we for time right now? Well, okay. So, we'll just go over some cases now. Hopefully I can figure out how the polls work or remember how to do that again. Okay, so case 1 is a 23-year-old gentleman who's presenting to the acute mental health unit. 4-week history of paranoia, thoughts that his previous landlord is stealing his blood while he's asleep, and hearing voices telling him to harm his ex-landlord. So he's been admitted to a mental health unit and started on treatment, we don't know what, there, and no past medical history. 3 days after starting treatment, he's awoken in the middle of the night with him complaining of a painful spasm of his neck. with normal vitals. And then on examination, his head is flexed and fixed downward and to the left, painful on movement and normal reflexes elsewhere. So I'll just put the poll up here. So what is the most likely diagnosis? Is that working? Sorry, let me just. Okay, so the polling started. Okay, so we've got 24 of 26 there, so that seems good enough. So yeah, so the results, most people are correct in that it's torticollis. Torticollis is specifically in the neck, whereas oromandibular dystonia is in the jaw, and it's sort of like a deviation of the jaw to a certain side, sometimes with protrusion of the jaw, of the tongue. Okay. So next is going to be what medication do you think is likely to have caused this? So we have fluphenazine, sertraline, risperidone, or aripiprazole. Okay, give you a minute. All right, so that's 24 of 25. Okay, we'll end the polling. All right, so 75% have said fluphenazine, 4% sertraline, and 21% is risperidone, 0 for aripiprazole. Okay, so the correct answer is fluphenazine. Fluphenazine is one of these ones that is first generation antipsychotic and has a high degree of side effects, and that's one of the main ones that we're worried about. So let me just check the cat that sorry. Okay. All right. So next question is, oh, sorry. I messed it up. Okay. So treatment, I guess I've already showed that to you. So treatment is either stop offending medication, procyclidine. I guess we don't need to do the poll for this one. So treatment is stopping offending medication, offering procyclidine, an anticholinergic, and reassurance. Sending to A&E wouldn't necessarily be an option. Paracetamol wouldn't be an option, and botulism to the neck is, that's last resort. So that's the answer to that for that case. Move to the next case. Case 2 is Mrs. P is a 56-year-old female, well known to mental health services with a background of paranoid schizophrenia. She's currently admitted in a mental health unit with a relapse of her psychotic symptoms, and she had been started on a new haloperidol depot, so an injection, 3 months ago. Staff have noted that she's been moving slower in the last few weeks, and you're the on-call doctor. You're called to the ward as she's fallen on the ward. You arrive on the ward, and she is on the floor and finding it difficult to stand up without any pain anywhere. Eventually, she does stand up with help from staff, and you do notice that she is having a shuffling gait. Her vitals are done, and she has a temperature of 38.7, heart rate of 106, blood pressure is 155/98, breath rates are 14, and sats are 97. And on examination, you note that she has stiff arms and legs and decreased reflexes. So for the polls, I'll stop sharing results. Sorry, I feel like I'm messing this up. Let me just check it. Okay. All right, you guys are figuring it out. I can also go back just if you want to, if you'd like to see the question stem as well. All right. Okay, so we'll end the polling there, and we'll share the results. So, 43% have put drug-induced Parkinsonism. Nobody's put serotonin syndrome correctly. Nobody's put infection, and 57 have put neuroleptic malignant syndrome. So the correct answer for that one is neuroleptic malignant syndrome, and I think it is easy to be tripped up by the fact that there are rigid muscles, shuffling gait, but these are also results of this sort of lead pipe rigidity that's present. So in someone who is having this lead pipe rigidity, there could be the potential for the shuffling gait, and I think just watch out for that word, because often we'll want to put drug-induced Parkinsonism because shuffling gait is is so strongly associated with Parkinsonism. But the main thing there is to look for the high temperature as well, and that would be why we're going for the NMS as the main thing. So the rigidity and the high temperature. So the next question is the best course of treatment for this patient. So we'll start the polling for that. So either we have stop offending medication, procyclidine and reassurance, sent to A&E urgently for temperature control bloods, or paracetamol, oral fluids, or again, botulism to the neck. Yeah, and everyone, yeah, so this is, we'll end that there. Yeah, so most people have answered correctly as well. Sent to A&E urgently for temperature control, bloods, possible ICU. One person's put stop offending medication. But I think that because this is NMS, you have to recognize that this is going to be the main treatment, which is sending them to A&E for temperature control. Okay, and oh, I did it again. Is that right? Did I? Okay, no, I didn't. Okay, so we're good. So next question is case 3. This is the last case we'll do. Mr. J is a 45-year-old male with schizophrenia. He's been on the same dose of oral amisulpride for 5 years. Prior to this, he had been on oral aripiprazole, which he relapsed with, and also has been on haloperidol prior to this when he lived in Germany. He stopped this as he didn't react well. Past medical history is nothing. So he comes to your outpatient clinic complaining of difficulty speaking. And when you see him, he occasionally opens and closes his mouth as if chewing gum. You ask him how to calculate how many weeks since your last appointment, and you note that this is becoming worse. On examination, his vitals are normal. There's no muscle rigidity elsewhere, and reflexes are normal. So what is the most likely diagnosis in this case? Tardive dyskinesia, akathisia, oromandibular dystonia, or none of the above? I'll go back here just so we can see, and yeah, we can start the poll for that as well. Is the poll on? Nah, poll's on. Poll. Okay, 19. We'll end the polling there. Cool. All right, and the results showed that 95% put tardive dyskinesia, nobody put akathisia, and one person put oromandibular dystonia. The reason that it's not oromandibular dystonia is because, mainly because of the nature of it. So in this person, it's not just happening once. Usually with the dystonia, it's a sustained contraction or a sustained reaction like that, as opposed to a constant sort of almost like a tick, which is happening. And also the other thing that differentiates it is the time frame that this patient was on this medication. So he was on this medication long term. So what would be the best course of treatment for this patient, given what we've discussed now? Okay, we'll end the polling there. All right, so 81% have put stop offending medication. That's the correct answer. Sent to Amy urgently, nobody, watch and wait. Some people have put that. One person's put botulism to the neck. I like your style. So we'll stop the offending medication. I think in this case it's important to do something to see if changing the medication would help. I suppose maybe decreasing the medication would have been a better option to see, but I think stopping offending medication is a reasonable option following a discussion with the patient. Watching and waiting, I guess that could be an option. I think it does probably depending on the patient's wishes as well. But I think having a discussion about what the patient would want would also be good. Botulism to the neck isn't treatment for much, unfortunately. So, and then what would an alternative treatment be for this patient, given given everything that we've heard about them as well. All right. Yeah, most people have voted, it seems. Yeah. So everyone has correctly put clozapine. I think haloperidol is definitely not an option. Fluphenazine is definitely not an option. Citalopram is an antidepressant, and clozapine is definitely useful because this patient has been on greater than 2 antipsychotics as well. So that is a correct answer. Well done. Yeah, so I think that's everything as far as the presentation. I hope that was clear. And now, are there any other questions? I know that someone wanted to go over things at the end again with regards to the mechanism behind it. But I guess before we do that, is there any other questions which have come about? So we'll go over. I guess we can just quickly go over the pathophys again. So yeah. So basically, how this works is that it's sort of about the interplay between acetylcholine and dopamine. So too much dopamine in the mesolimbic pathway causes psychotic symptoms. We give them antipsychotics to decrease the dopamine, which leads to this receptor blockade of the D2 dopamine receptors. As a result, in picture B, as these D2 receptors are blocked, the neuron, the cholinergic interneuron, doesn't necessarily know how to regulate itself. And what happens is that there is an unobstructed release of acetylcholine as a result. Now, how we treat that acetylcholine usually is by giving them anticholinergics to decrease the symptoms of stiffness and dystonia. However, after a certain period, that is not as much of a problem, either through treatment with acetylcholine or the other issue which results in the long term is that dopaminergic receptors are suddenly upregulated, meaning they either increase the amount or their sensitivity is increased. And therefore, the slightest stimulation can lead to very big and strong and not necessarily equal results. So that will lead to these tardive dyskinesia results. And it's a very complex process as well. So I hope that makes sense. And then one thing from the chat. Oh, yeah, the feedback as well. If everyone would just be able to do the feedback, that would be super helpful for me because I'm also a trainee. Yeah. Yeah, thank you everyone for coming. Oh, there's another question. Cool. Yeah, no problem. Any other questions about psychiatry in general? It's super fun. It's interesting. It's not as stressful. I'm happy. Cool. Yeah, thanks you guys. Thanks for doing the feedback.